Hi friends, I'm Dr. Ajay Arora. So today we'll be discussing the basics of retinal lasers. The aim is to make you understand what lasers are all about, clinical examples of lasers as we use them today, uh, a little bit about the history of lasers, and what is the future of lasers. So as you know that lasers have been used around the eye. They started off with treatments for the retina. The initial thing was of diabetic retinopathy. And then we have lasers for corneal procedures, lenticular procedures, iridectomy, and trabeculoplasty. So let's have a look at what lasers are all about. When you look at the normal light, it follows the Huygens wave theory, and you have different wavelengths. The peaks and troughs do not match with each other. If the same light is passed through a filter, you will have a monochromatic light, but the peaks and troughs do not match, so they are not in sync. If we have a situation where it's a monochromatic light and the peaks and troughs are identical, then this is known as the coherent light. And that is what is essential aspect of lasers. So laser acronym stands for light amplification by stimulated emission of radiation. How is it is produced? You have normally electrons in different orbitals, which you remember in your chemistry. When one electron moves from a lower orbital to a higher orbital, where it is not stable and it comes back to the lower orbital, it releases energy in form of a photon. Now, this process of release of energy in photon can be activated by a pump into a laser medium, and that could generate numerous photons at the same time. So basically, a laser system will have a pump, which is an external source of energy, you can see here, which acts on the laser medium. The laser medium historically was gaseous, which was argon and krypton laser. Then came in the tunable dye laser, and now we have the semiconductor laser. So this is the heart of a laser machine, is the engine of the laser machine, where the electrons get pumped to the higher orbital, they fall down, release photons, and this process of going to a higher orbital and falling back, when it involves the entire medium, it's called as a population inversion. When these electrons, they hit a mirror which is fully reflective on one side. On the other side, there is a small opening which allows the laser beam to be to exit the cavity, and then the laser is activated and released from the system. The credit for what we have today goes to Dr. Meher, who way back in his 40s experimented on his terrace to capture the solar energy and convert it into a system so that he could photocoagulate the tissues. And I would advise you to read this article which was written by him. He went on to make the Zeiss xenon photocoagulator, and you can see these burns being done out around a horseshoe tear. They subsequently moved on to a Log3 Clinetics xenon photocoagulator, and I had the opportunity of using it while I was at Jaipur Pondicherry. And none other than Steve Charles made an endolaser probe attachment to the Log3 Clinetics xenon photocoagulator, which was used. Now let's have a look at the tissue interaction of the lasers. It is absorbed by the retinal pigment epithelium and the melanin in the choroid. So what happens is that once the laser beam is absorbed, there is a local rise of temperature and a coagulative necrosis, which leads to the effect of laser. Initially, the lasers that were used were blue light, 488 nanometers, and 514 nanometers, but it was found that these laser beams were absorbed by the xanthophyll and hence were damaging to the macula. So they have been given up, and we have lasers now in the green range, 532. 577 is the yellow laser, and we have the diode red laser that is 810 nanometers. We were very fortunate that the mother of all multicentric trials was the diabetic retinopathy study, which answered a few questions. The questions that were asked were, does laser photocoagulation help to prevent severe visual loss in cases of PDR? Is there a difference in the efficacy and safety of argon versus xenon photocoagulator? And which stages of retinopathy benefit most? So DRS demonstrated that more than 50% reduction in the rate of severe visual loss in eyes treated with PRP in cases of PDR when compared with the untreated groups over the period of 5 years. It also recommended prompt treatment of eyes with high-risk PDR. Then came up the early treatment diabetic retinopathy study. It was again a randomized prospective study, and it answered a few questions. It showed that focal photocoagulation decreased the risk of moderate visual loss and reduced retinal thickening. Early scatter photocoagulation could be considered in cases of severe NPDR, and aspirin has virtually no role. So these are some of the pictures of pre-anti-VEGF era. So this is around 2004, where when we had patients with diabetic macular edema, we used to do an angiogram, identify the leaking microaneurysms, and then carefully with the area centralis lens, with a 50 micron beam, laser the microaneurysms. And you can see here how these the edema has reduced. We didn't have OCT also at that time to show that the edema has come down, but patients used to recover, visual acuity used to improve, and that is how we used to do it. For diffuse diabetic macular edema came the modified grid laser, and then we had a typical grid laser which was done, which was kept about 500 microns away from the disc. It was about 300 to 500 microns from the center of the macula, superiorly, nasally, inferiorly, and about 500 microns temporally. And this entire area was, was 500 to 3,500 microns. And it was shown that if you had a light gray intensity of burn, you could actually treat the microaneurysms directly. And the distance between the burns was about one burn width apart. And this did result in reduction of diffuse diabetic macular edema. With the advent of anti-VEGF, now we do not give laser to the central part of the macula. Center involving diabetic macular edema is treated by pharmacotherapy, while a non-center involving or an extrafoveal diabetic macular edema is treated with focal laser. Like in this particular case, you have the center being flat. There's an extrafoveal diabetic macular edema. So you identify the microaneurysms. You should be able to differentiate between a microaneurysm and a hemorrhage. And once you identify the microaneurysms, you go about treating them. And one could use a green laser or a yellow laser, and it does well. I'll show you some cases. So this is a patient who is a diabetic for 10 years, hypertensive, is a non-proliferative diabetic retinopathy with an extrafoveal edema, visual acuity of 6-9 parts, was treated with an area centralis lens by a grid photocoagulation, and the patient did well. So this is another patient who had a succinate ring, which was away from the center. The first thing which is important is to ensure that the patient gets a good metabolic control. Once you've done that, you can go ahead and do an extra focal laser, which was done in this case. And this is 4 months after the focal laser was done. And this is about 8 to 9 months after the focal laser done. You can see how beautifully the macular edema has reduced. So this patient did not need anti-VEGF and responded well to extra foveal laser photocoagulation. When you have a patient with a high-risk PDR, you must follow your methodology of doing laser. What I do and what a lot of people recommend is that you should treat the inferior half first, go about treating the nasal part superiorly and then temporally. The reason for treating the inferior half is because uh, in case there is an accidental bleeding in these cases, then the blood will all accumulate inferiorly. And if you have already treated the inferior half with laser, you will still have opportunity to treat the rest of the retina with laser photocoagulation. So this is usually done with a Mainster wide field lens. We use the Mainster 165 and we use a pattern laser. Like this is an example of a pattern laser being used. So you could use a Mainster wide field, Mainster wide field extra, or Mainster 165 lens. And a pattern laser gives you more spots at a single press of a foot switch. Hence, each burn duration becomes shorter. Normally, it's about 100 to 200 milliseconds, but in a pattern laser, it's about 10 to 30 milliseconds. Hence, the total amount of energy delivered to the area is much lesser. There's lesser pain by the patient, and hence it is safer. If we look at the change of laser burn in a continuous wave laser, which is what is seen here, there's an expansion of the laser burn. But in a pattern laser, you can see the burns are much more homogeneous, regular margins, and they don't expand like if we do a monospot laser as a conventional methodology. So the rationale of lasers in proliferative diabetic retinopathy is to actually convert a hypoxic retina to an anoxic retina, which will reduce the formation of vascular endothelial growth factor. To be able to do that, one could use a slit lamp delivery system or an LIO, as we'll see here in this particular So those are the two basic methods of doing laser PRP. Now here you have a patient with a horseshoe tear and another tear which is operculated with a free-floating operculum. We go ahead and do laser with LIO, laser indirect ophthalmoscope. You can give 1 or 2 rows of laser burns around the break, and you can see a nicely done laser, and the horseshoe tear will stay there. What is important is to do laser in the area where there is no fluid. So it should be done as soon as this is a very large horseshoe tear, it should be done. In fact, a patient walks in, you should tell them that it should be done immediately on that day, no postponement, no coming back and getting it dilated again. This is a patient who has got an atrophic hole in the temporal periphery. You can see this hole. This was lasered by LIO with 2 rows, and the patient seems to be doing well. This is a patient who had an advanced retinal detachment with PVR D3. Patient was operated. This is status post VR surgery, silicone filled eye, where a 360-degree laser has been done. You can see the buccal effect, and the patient did well. This is a diabetic patient who has had recurrent vitreous hemorrhages, underwent panretinal photocoagulation and a vitrectomy, and had subsequent bleed once more. And once the bleed subsided, cleared up, we did a fluid air exchange. We went ahead and did a wide field angiography and found there was an NVE. There were large areas of capillary non-perfusion, which were lasered, and the patient stopped having retinal bleeds. This is a very interesting case of a patient with a persistent diabetic macular edema, 61-year-old patient who was diabetic for 10 years. Patient had been receiving anti-VEGF injections. We did a wide field fluorescent angiography. You can see here NVE and large areas of capillary non-perfusions in the periphery. Patient underwent pan-retinal photocoagulation. There was treatment of the capillary non-perfusion areas, targeted treatment of the NVE. Patient got stabilized, did not need recurrent anti-VEGF injections, and the patient was stabilized on laser photocoagulation itself. You can see the macular edema has reduced. The cystic spaces may not go away, but the patient is stable with no exaggeration of macular edema. If you do a lot of laser at one go, you may end up having choroidal detachment. So it's better to divide the PRP into different sittings. We normally do it in 2 or 3 sittings. But a pattern laser, you can actually do it in 1 sitting or maximum 2 sittings. Now, before I close, it's important that for the youngsters, it's important to know which lasers are available, what are the delivery systems, what spot size are available, single spot, multi-spot, continuous wave laser, or transpupillary thermotherapy laser. You should be aware of all the possibilities that are available and make a judicious decision based upon the economy and what your needs are. So laser photocoagulation, ladies and gentlemen, was relegated to the backyard with the advent of pharmacotherapy, but now with better understanding and with better options of lasers available is making a comeback. PRP has remained effective for PDR over the last 4 decades, and it still remains so. Laser photocoagulation is the best way to treat focal extramacular edema, and laser photocoagulation is the best way to achieve retinopexy. So in addition to all this, we must understand that there are newer options available like a subthreshold micropulse laser, Navelas laser, or a nanosecond laser. I've been using subthreshold micropulse laser. It's a very effective way of treating central serous retinopathy and macular edema due to many other causes, because it helps us to restore the sight without being very destructive. So thank you for being there.